Hello everyone, today I am going to discuss a case that came to my OPD. The patient is about a 55 years old female. Okay, so whether she is having any comorbidities? Yes, she is a patient on treatment for diabetes mellitus and dyslipidemia. So what are the chief complaints that patients developed? To be frank, this patient developed dyspnea, that is shortness of breath, and anxiety problems. And for routine checkup for anesthesia, she took an ECG, that's why referred to the physicians in cardiology. So let's see. Here, this is the ECG serial ECG that they have taken, and what all problems that we are finding here is we should check. First, we should see whether the rhythm is regular or irregular in this ECG. The rhythm is clearly irregular. Why? You can see that the lead to rhythm strip, one large, one small, one large, one small, one large, and that too occurring in a irregular fashion. So that is a irregular rhythm. So in irregular rhythm, how will you calculate the rate of the ECG? The rate of the ECG can be calculated. You check the 30 large square or 6 seconds. You check the 30 large square or 6 seconds. When you are checking the 30 large square, start from here. This is a 1, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. That comes to 30 large squares. So from 30 large square, how many QRS you can appreciate? You can appreciate here 1, 2, 3, 4, 5, 6, 7 QRS complex. You multiply by 10. So the rate is 70 beats per minute. Okay. So now you check the PR interval. So here is the P wave and this is the PR interval. You see here clearly, you see here this one PR interval. So this PR interval should be always less than one large box. So it is a number of small boxes 1, 2, 3. So 3 small box PR interval. So let's say that the PR interval is 3 small box, which means each small box is 0.04 milliseconds. So it is 120 milliseconds. Normal PR interval is 120 to 200. So it is a normal PR interval. Okay. So next we discuss about the QRS complex. You see here the QRS complex. This is a normal rhythm P. In that you see the QRS complex is about 2 small boxes. The QRS complex is 2 small boxes, that is 0.04 into 2, that is 80 milliseconds. So normally QRS complex is less than 119 milliseconds. But we can here found another ectopic or ventricular contraction, premature ventricular complex, this one. So we have to find the interval of the QRS interval in such complexes also. It is 1, 2, 3 QRS small boxes in PVC. So you say that the PVC, that is premature ventricular complex, has 0.04 into 3, that is 120 milliseconds. Okay, you understand that? Yes, I have. It's a regularly irregular, we could say, if it is. So we can finally decide this ECG as a patient is having a sinus rhythm with premature ventricular contractions. That is the diagnosis. Okay, so it comes under ventricular arrhythmias. You see ventricular arrhythmias. There are premature ventricular contractions, there are ventricular tachycardia, there are ventricular fibrillations. Okay, these are the ventricular arrhythmias. So when we discuss about the ventricular rhythm, the failure of the atria and AV junction to initiate a beat. In such cases, these ventricular rhythms occurs. You see some ectopic foci. These are ectopic foci occurring in the ventricle. The SA node and AV node fails to generate, that is the ectopic beat interrupts the normal rhythm. The ectopic beats which are originating from the ventricle, you see this one. These are the foci, ectopic foci. How these foci came, we don't know, whether it may be STEMI, whether it may be STEMI or any other infarction can trigger that foci and produce ectopic rhythms. So that ectopic beat, so these ectopic beats, interrupts normal rhythm of the heart. That is the case. So see here, example here, let's see the example here. So this comes a normal sinus beat rhythm here, normal rhythm beat, and this is also a normal rhythm beat. In between you see an abnormal ventricular premature complex. These are called ventricular premature complexes. Okay, ventricular premature complexes. You see one thing, how these ventricular premature complexes are formed. There are some causes. When you are discussing, one common cause is irritable foci. So irritable foci in ventricular wall or conduction system. Second one, re-entry phenomena. So re-entry phenomena means a particular foci reinitiate the electrical current. So the cycle continues. That's a re-entry phenomena. So what are the significance? If a foci is there to trigger this current, what are the significance? So one significance, it can precipitate to ventricular tachycardia. And also it can precipitate to ventricular fibrillation. Also it can cause decreased cardiac output. So what does it mean that if the patient is also symptomatically better or there is no symptoms, even if there is no symptoms, we should work up the patient because we want to find the foci of that premature complex. Do an echocardiogram or any other modality, for imaging modality, and find where is the foci. The decreased cardiac output is one complication because you see that normally the ventricle beats in a regular rhythm that produce the cardiac output to perfuse the body. In between some ventricular premature beats occurs, that premature beats does not correspond to proper perfusion of the body. So the patient may go for insufficient perfusion. For example, if the beats is 80 beats per minute, it won't be correct. In this case itself, I have shown that the beats 70 beats per minute, but in between these beats won't perfuse the body clearly. So there is a lack of perfusion. One of the type of ACG, you see the rhythm strip. There is a normal beat here. There is an abnormal beat here. There is a normal. There is an abnormal. Likewise, the rhythm is regular, but it is regularly irregular because these abnormal beats are coming in between two normal beats. So you can say it is a ventricular bigeminy. One normal beat, one abnormal, one normal, one abnormal, one. So this is a ventricular bigeminy, that is normal beats followed by abnormal complexes. So this is a case of ventricular bigeminy. So in this our case, this patient who is 55-year-old presented with these problems. This is also a rhythm. Look the rhythm strip clearly. It is a ventricular bigeminy. This is a patient with PVC, that is a ventricular bigeminy. Second type, you see two normal QRS complexes, two normal rhythm, which is normal. Normal QRS complexes, P wave, normal beat. The third beat is abnormal. So after that also 1 and 2 are normal, the third beat is abnormal. So for every two sinus rhythm after following a premature complex, this is called ventricular trigeminy.
Let's see this ECG lead to rhythm strip. We can find three normal sinus rhythm 1, 2 and 3 followed by a wide complex QRS complex. Similarly 1, 2, 3 followed by a wide complex QRS complex. So you see every fourth beat is ventricular premature complex, that is 3, 4, that is ventricular quadrigeminy. So we can label this ECG as ventricular quadrigeminy. Similarly, you see another ECG case. You see the lead 2 rhythm strip. You can find 1, 2, 3 and the fourth one is narrow complex, which is wide QRS complex with a narrow potential. Another, see the peaked QRS complex in between the sinus rhythms. So we can label clearly this ECG as a case of ventricular quadrigeminy.
In this ECG, you see that you see two QRS complex which is normal, then form a couplet. This is two normal sinus rhythm, then form a couplet ventricular premature complex. These two normal sinus rhythm, then form a couplet. So it is known as a premature ventricular complex couplet. This is also a PVC type. Okay. So this is a ventricular complex problem. So till we discussed the premature ventricular complexes. So in premature ventricular complexes, we told that is the ectopic foci is triggering the signals. So most patients do not require treatment, but if you see a patient with a ventricular premature complex, you should definitely do an echocardiogram to find the foci. Okay, and you treat the underlying disease. According to Harrison, low potassium, that is hypokalemia, and low magnesium, that is hypomagnesemia, they are risk factors. They are risk factors for ventricular fibrillation in patients with STEMI. Okay. So what do you do? You should reduce the potassium, reduce the risk. The serum potassium concentration should be adjusted to 4.5 milliequivalents. Okay, and magnesium, serum magnesium to about 20 millimoles per liter. Okay, that's the Harrison is saying that. So if a patient is symptomatic, patients, the beta adrenergic blockers can be used. We can use beta blockers. The beta blockers agents are effective in abolishing ventricular ectopic activity in patients with STEMI and in prevention of ventricular fibrillation. So it prevents ventricular fibrillation and also it prevents the ventricular ectopic activity. So if the beta blockers fails, or in asthmatic patients, next option is you go for catheter ablation, ablate the foci. Catheter ablation. What is catheter ablation?
So in this case, we use a catheter via the veins from arm or groin, reach the vena cava, enter using the guide wire, it enter the heart. Then after entering the heart, we find that where is the problem, which foci is producing the abnormal rhythm, we ablate it.
So finally, that is about this ventricular complex, and thank you for listening. Have a nice day.